Welcome back to another episode of Parenting Shrink Wrapped. Sam here with Melissa as usual, and our special guest today is Dr. Afshan Sultana. She is a child and adolescent and adult psychiatrist out of St. Louis, Missouri, where she did her residence and fellowship training at Washington University. And today's topic is one that I think is heavy on the minds of plenty of families, but nobody wants to be in the club where this is on your mind. And that is adolescent depression. We're going to talk a little bit about depression today, how to recognize the signs, and what we can do about it. And Dr. Sultana is going to give us some frameworks to think about in terms of, how to distinguish between what is kind of concerning and what is clinically, needs attention. This is a topic that we've had requests for, and it's a sensitive one. And so we're looking forward to going here with love, with compassion, but also with some sound information for you as you navigate what is probably a really rough parenting patch if this is something that's relevant for you. So Dr. Sultana, thank you so much for joining us today and for being willing to wade in these sensitive waters with us.
Thank you for having me, of course.
Tell us a little bit about yourself, about your practice, and about the work you do to treat young people who are dealing with this horrible circumstance.
Okay. I'm a child and adolescent and adult psychiatrist. Most of the population I treat are young kids and teens. And depression is one of the very common presentations that patients present with. And then I hear so many questions, questions in parents group, such a common issue. I would like to discuss the basic concepts about depression. Basically, it's a very huge topic beyond the scope of the time we are given. So what we'll try to do is basically touch base on some key factors regarding depression, some things about the diagnosis, the misconceptions about treatment, and things of that nature. So most importantly, depression is universally very common in adults, but it's also very common in children and adolescents. Especially in teens around puberty when the hormonal changes and other things are happening. The mid-teens, 15 to 17, a lot of academic, social stressors come along, and that can affect their presentation. So firstly, we'll talk about some the biologic or psychosocial contributors to depression. So
biological. 1 second before let's just make the distinction here. So biological, we're talking like what's happening from within the body, right? And when you say psychosocial, I assume that means like environmental or factors within a kid's life or within our society that could be contributing to depressive symptoms. Am I getting that correct?
Yes, absolutely. So biological factors are genetic makeup. If we have history of depression in our family, mental illness in our family, thyroid disease, medical disease like thyroid disease, vitamin D deficiency, sometimes external use of drugs like illicit drugs that can also, contribute to, of course, the presentation of depression. Psychologically, basically, the kids or patients patients with depression, they have cognitive constructs around shame and guilt, which plays a very important role in how they see themselves and how they see the environment around them. So those
I see that so frequently in when I'm working with kids or when I'm working with families whose kids are depressed. And what I don't know, what I can't always tell if I'm like late to the party, you know what I mean? Like if the depression is already set in, is the constructs around shame and guilt or lack of self-worth, like did they exist in some form before, or are they the result of depression, or is the answer yes? And I find it's usually a little of both. Would you agree with that? Like, do you do both? You treat people clinically. Would you say the same thing? Like when when young people show up that they've got these negative self-images, but it may have existed before there was a clinical presentation of depression.
Sometimes,
Yes.
yeah.
Yeah. Yeah. Okay.
Yes. So there's a genetic makeup, your genes, then your environment, then your psychologically where you are. You grew up in an environment which was not validating for you, and then you have low self-esteem, and then of course, then the external stressors happen, like in a teen's life, a breakup, a romantic
Yeah.
breakup, academic stress, abusive parents, use of drugs, loss of loved one. All these things then act like they precipitate depression. So you have biological or genetic factors, then you have those constructs or the way you think about yourself or you the world, and then a stressor happens and boom, you see the presentation of depression then, right? So that's usually the causes. Then the other thing, the other important thing about it is that very commonly I get asked, like, how do we distinguish between depression and the general teen attitude? Because
Yeah.
teens have ups and downs.
Yeah. Yeah. I was going to ask
They're
that question.
moody, right? Like adolescents are moody creatures.
Absolutely. So, but basically, the studies found that the emotional ups and downs in a teenager, they are short-lived. So they may be snarky and snap at you and acting irritated, but as soon as their friend shows up, they're smiling, ready to go out, have fun. So they come back to their cheerfulness. But in depression, uh, it's a longer period of time that the depressive symptoms persist for a longer period of time. They don't up and go down. They'll last a week or so, along with other constellation of symptoms that we're going to see in depression. So basically, it's a mood, right? So it could be, usually in teens, it's not like sad and mopey. It could be sad and mopey and crying, but it could be very irritable, angry
Mm. Yeah.
outburst, very cranky. Those are the things that are very common in depression, the how they present. And along with it, loss of interest in previously enjoyed activities. That's one of the main criterias of depression, that you have a bad mood along with the loss of interest, such as, you know, your kid is a soccer player, he enjoys soccer or he enjoys playing a musical instrument, and now he's not into it anymore.
I
He
find that it's one of the hard parts for parents who are dealing with depressed kids is um, sometimes like kids who are not suicidally depressed, who are, hanging in there and functioning in their life, do have moments where they smile. They do have moments where they're like hanging with their friends, and their parents are like, they seem okay. They're just jerks around the household, or they're telling me that they're depressed, but then I don't see it consistently. Like there are times when they're not. Like they seem to be going out and playing soccer, and like they seem pleased when the team scores a goal, and that I think is a hard thing. That's hard for parents to tease out. And sometimes I've worked with families who have been like, I really don't think so. I think this is my kid being dramatic, and it can take. Parents know their kids better than I do, So like when a parent says that, especially if they're involved and on it, I'm like, okay, well, let's just keep an eye on it then. Let's see. Like my inclination says maybe depression, but it's not. It's not firm. So there's a lot of walk in the line, I guess, in some of these diagnostic criteria with some presentations of depression. And then it ends up being like it takes longer to get a diagnosis when you get a presentation like that. Does that, first of all, am I the only one who's seen what I'm talking about?
No, definitely not.
Not right? And am I right? Like it takes longer to get to a place, because you can say like, I really think the kid's depressed. I really think so. But like the parents need to be the one overseeing treatment. So this has to be.
But I think too, Sam, like a lot of times, like sometimes when I see a patient for the first time, particularly like the first time they walk in the office, I always refer to diagnoses as like a working diagnosis. Like, and I may say like, I think this is what is going on, but I'm not sure. And like, I want to get to know somebody better before I fully finish developing my treatment plan.
Right.
Like, it may not be always like that first visit. Like, there's a lot sometimes to tease out with an adolescent and with the parents and the dynamics and like learning all of those nuances. Like sometimes, I mean, I spend typically 90 minutes with new patients, and sometimes that's just not enough. And
Right. Right.
That's what I try to tell the parents. I mean, it's a human being we're evaluating who's still in the process of development, a lot of psychosocial, psychological stages that they're going through. And it's new to them. They have the parents sometimes feel that, oh, that was such a small thing. Why would you get depressed about it? But for them, it's a big deal. So acknowledging that. But yeah, that's true. It's based on your environment, based on the dynamics, the family dynamics. And exactly like Melissa, sometimes you can tell what's going on, and sometimes you need so much input, like, what environments are they? Sometimes parents are not home, as the grandparents, the kids are with grandparents most of the time. So what dynamics is going on? So I always say that, yes, I'm here to assess, and you're bringing him here to get assessment. So sometimes it takes time getting all the information for a child and adolescent. We work with not just the parents, sometimes the grandparents are involved, sometimes uh, family services or foster families are involved. Sometimes we have to reach out to school. What is the school noticing about the kids? So there's so many resources, and that's why it takes longer for us to assess a kid, because there are so many people involved in their lives, and getting information from each environment. Let's say school is doing great, everywhere going doing great, but in the at home he's acting like that. So maybe it's the home environment. Maybe, I mean, I don't know. So
Yeah.
that's what we try to figure out.
Right. Right. So
So
we've got kind of like what it looks like. Have we missed any of the big cues? We've got,
so
irritability, sadness, withdrawal from things that used to be fun. Are we
and
missing
then
any of?
sometimes, so and then the other constellation of symptoms, like your sleep is disturbed, maybe hard to fall asleep or wake up too early in the middle of the night, appetite is disturbed. One of the presentations sometimes is, especially in high achieving kids, the presentation is not that of depression, but they bring the kid uh, because there is an academic decline in
Mm.
grade and school work, and suddenly the grades are down, so the parents are worried what's going on. Maybe they have ADHD, because the kid says, I cannot focus in class, I get distracted, and that's how they're presenting. But evaluation, then we figure out that, hey, focus and attention is a very common problem in so many of the mental health issues. It just doesn't automatically mean ADHD. So then we assess and say it's in the context of anxiety or depression, and that's how we go about it. So that social relationships changing, their patterns of behaviors are changing. That's what we're noticing, right? Of course, if it is serious, like their self-harming behaviors or suicidal thoughts, then you need attention immediately, of course. But with these symptoms, there is a pattern of symptoms that's continuing for some time. So, in terms of what to do, sometimes some of my friends ask that in order to for us to get into therapy or seeing a psychiatrist, it takes time, right?
Mm-hmm.
What do I do in the meantime? How do I handle these situations? So that's another common question that I see. So I would like to address that. Is basically, be present. Be present in the life of your kid. Know what their schedules look like. Know who their friends are. How do they behave in certain situations, when they're excited, or when they're sad, or when you're angry. So you will have an idea. If you notice something like that, reach out to them. Say, hey, I feel you're not, uh, or you can reach out, like saying that, hey, something's up. I have noticed that. I want to reach out. And they may say, oh, that's nothing. You're thinking things, and then you can reach out that, hey, you know what? I noticed that these days you're not sitting for family dinner, or you're skipping your practice, and that made me concerned. So you're bringing attention to the facts that are going on. I'm not just like making these things up. And so talk to them about these things. Try to listen to what they have to say. Again, don't minimize their feelings and emotions. If they finally open up and say, oh, it's a breakup. Now, as an adult, you're thinking, oh, it's just a breakup, and they'll get over it. What's the big
Yeah.
deal? But for them, it's real. So
Well,
you're going to.
what I say to parents, I'm like, that's supposed to rock their world. Like they're
Absolutely.
not supposed to be upset about bankruptcy at age 30, right? The troubles that they're dealing with are age appropriate troubles, and they're supposed to have big emotions around them so that they learn to manage them and integrate those kinds of things so that later, not that a breakup's ever easy under any circumstances, but like, you know, when we're older, a breakup doesn't have to derail our entire life. But in high school, my gosh, how many
It
times
totally does.
I've had so many crying kids in my office who cannot function at school because a breakup happened during lunch, and like I just have to send them home. You know, sometimes like not when I was a school counselor, so, and that's not a depressed kid. So we've got like if that happens, and you, as you said, Dr. Sultana, like if you've got the propensity for depression, either because of thought patterns or you know just like where you were so psychologically beforehand or a genetic predisposition, you know that can it's a
Right.
yeah
Precipitate, you know, a significant depressive episode in
right
that.
right but
So
like those kind of things, like you said, we may have a tendency to minimize our kids' struggle, but I'm like, I caution you to celebrate that this is what they're getting, like it's age appropriate things they're getting upset about, you know, like, and they're supposed to get this upset.
And I think too, like you need to think, if you can, like if you remember or can try to remember, how did you feel about that at that age, right? Like, and sometimes it's hard to remember that, but like if you experienced a breakup as a teenager or got rejected by someone you liked, like that really hits hard in those years. We you know, it can hit hard in adulthood too, but you know, I think you have different coping abilities that you've developed, whereas you have a developing brain at play, you have developing personalities at play. Like you're not armed with all the coping skills at 15, 16, 17 years old.
Right.
Parents forget sometimes that we are at this age, we have been through things, so we know what to, you know, worry about or not. But at that time, it's very important. So not to minimize their feelings, because then they're going to shut down and not come.
Right.
No, you have to validate.
Yeah, exactly. And so that's also very important, that while they are talking to their kids, sometimes, you know, there are hard things that are being talked about, especially suicidality or something like that. And it's very painful for parents, of course. They're taken by surprise. But they have to stay calm so they can create like a safe environment for their kids so the kid can reach out. So it's very, very hard on parents. They don't know how to navigate this time or these kind of serious issues.
Well, I
So
just want to pause there. If your kid says that they are, like, if they're having suicidal thoughts, yes, stay calm, but also call someone. Just like, you know, like call the pediatrician.
Can help.
Right. Like, they shouldn't be dealing with that. That's like, that's not something that you just wait and see if it disappears. Like, if your kid says that that's happening, at a minimum, call their doctor, because that's usually who you can get a hold of quickly, and get some guidance on whatever next steps should be. Right? Would you agree with that? As
absolutely.
yeah, if you don't have a therapist already, you know, but
I mean, I tell, like, my auto reply, and Dr. Sultana, I'm sure yours is similar. Like, my voicemail, my auto reply is like, if someone is experiencing a crisis, it's like, call 911, go to the emergency room. There's national suicide hotlines out there. Like, those resources, you know, they're there for a reason. And yes, stay calm. I agree, Sam, but like, please don't sit there like freaking out and trying to like manage this on your own. And like, even if you are a mental health provider and your kid is struggling like that, like you need to reach out for help.
Reach out. And also, if you are worried that your kid is suicidal, and because they're down, because they're showing some of these other symptoms that Dr. Sultana has just shared with us, it's okay to ask them. You're not going to plant the seed. You don't make a kid suicidal by asking. You can say,
there's a lot of research behind that too.
Yeah, you can say, like, are you having thoughts of hurting yourself or harming yourself? Has that occurred to you? And if they have, and they say yes, well, thank goodness you've just made it safe for them to share that, and they don't have to carry it all by themselves. And if they haven't, if they say no, great. That you don't have to worry about that. You know that you haven't hit that, but it's okay to ask, and you should.
Absolutely, you have to ask, and that's a very important misconception around it, that, oh, maybe if I ask, I'm going to put that seed. No. I think in this world of social media, everybody's aware, and kids are very knowledgeable about these things, and so it's important to ask and do and obviously monitor for safety. It is significant suicidal thoughts with a plan. They know what they want to do or how they want to do, or they really, so you have to monitor for their safety and reach out for help, like exactly 911, take them to the ER. And sometimes I also explain that sometimes parents feel, or sometimes the kids are upset with the parent.
Yeah.
Why are you taking me to the
Yeah.
hospital? Why are you taking me? You are the worst parents ever. And then they kind of, play at the guilt of the parent, and parents are really, they don't want to upset their child further because they're already struggling. That's when I say that, hey, if your kid had a fracture, what will you do? If they don't want to go to the OR and get it fixed, would you keep them at home, or would you take them to the OR and get them, get their fracture fixed? So it's something like that. It's a medical illness. And that's very important. Again, taking an offshoot, the biological, the medical model of psychiatry. That's the most important thing. People sometimes feel that this is something they make up in their head. They can talk themselves out of it, or something. So though sometimes there are cognitive distortions, but depression is a medical illness. So we have to see it that it's a medical illness. It needs help, just like somebody having a heart attack or having a fracture. You're not going to think through, am I being a bad parent for taking them to the OR? So that also helps them immensely. That is another misconception. Good, you brought it up. So yeah. And then
before we get into treatment, I've got one more parenting question. And that is, because this is another thing I see. When you're dealing with a kid who's not suicidal, but who's depressed, maybe he's in treatment, maybe it isn't, maybe isn't, it doesn't matter where, but they still have life obligations. And you can, and in high school, like particularly, it's like, you got to do this now because like this is when tryouts are, or like if you want a summer job, you have to look for it during this month, like the expectation is you'll be better later, but if you let this door close now, you're not going to, like, these opportunities aren't going to be there for you. So parents have this razor's edge they've got to walk between being sensitive and understanding and kicking kids in the pants a little bit, and they don't know how to balance that. And I don't know if either, like, any recs on that.
Dr. Sultana, I'll let you answer first, and then I'll give my 2 cents.
So I mean, I think it depends. You know your child. I mean, I would say you know your child better if they were always very disciplined and very responsible doing things, and suddenly there's a change, then there must be more to the picture, and you have to show them some grace and be gentle with them. You're not, again, I say that to my parents. If they have a 105 temperature, you're not going to ask them to go do their homework, right? So give them grace, figure out what's going on. But yeah, they're enjoying life, playing soccer and on the video games, and suddenly there's, they can't do this anymore. Then you'll have to figure out that, is this something that they're struggling with, or is this they're avoiding it? Because, and again, communication. Is there something they're avoiding because they're so anxious about it, or something they're not interested, or they're just being lazy about it, or there's depression going on that is affecting their performance? So having patience.
I was gonna say, like, I think it's a time where I usually end up providing a lot of psychoeducation to families that the kid really may not be capable in that moment.
It's a can't, not a won't.
It's a can't, not a won't. I agree, Sam. And usually what I end up recommending is, like, if it's an academic thing, right? Like, this kid didn't turn in any assignments and now is going to, like, flunk. Like, usually involving school and letting them know what's going on and forming a plan from there can be immensely helpful. It also usually ends up reducing some of the parental anxiety that ends up going on, because a lot of parents end up highly anxious then that, like, oh my gosh, my kid's gonna fail, and that spiral kind of happens. And then the kid might also be experiencing same anxiety, but just is not capable at that present time.
I love, so that's another reason to consult an expert. Like, if you're worried about how to be there for your kid,
Right.
Get some input, learn a little bit, which
Right.
we're talking about here.
That's what happens. Like, if I'm the psychiatrist, then of course, I'm going to work with the parents, but working with the school and knowing what's the relationship of the kid with the teacher or the parent with the school. Sometimes if they feel that it's not a strong relationship and they're not um, trusting, then they might not reach out. But generally, schools are very good at accommodating these kids with their short-term, resources, providing them or help or things like that. If it's significant, we can have like a homebound situation where they're home for a few weeks and then, being taught out of the school. So there are so many things that are. There are resources that we can utilize for kids when this is happening. So the so the but the for so those were for the serious, but for depression, I mean, basic treatments are obviously therapy and medications. How when to use therapy and medications depending who you get into first. Usually my patients start with therapy, and the therapist is recognizing that there are so many self-doubts, there's so many anxieties or so many symptoms that they're not able to work on the symptoms without medication, probably because it's not resolving. So then they're working, and then the therapist recognizes, hey, this kid would benefit from medication. Because after taking medication, sometimes you're in a place where therapy also works. You're able to
Yeah.
understand the thought and then, adopt those coping skills. So therapy will be age appropriate, cognitive behavioral therapy or interpersonal therapy, depending, and then working on on those constructs, and then working on your coping skills, problem solving skills, and then mostly the kids are coming either from the therapist. Um, so the so if I get a patient and I'm treating them, the most important thing I can do is not just like write them a medication, is just the psychoeducation part, helping the families understand about the diagnosis of depression, what's the prognosis like, what are the contributing factors, what can help them, what can worsen them, and some of the misconceptions about treatment. So the most important thing, again, I say, age appropriately, what are the symptoms, and like, I think we discussed earlier, that is it somebody just using, or some using those symptoms versus actually depressed, so assessment goes into that. And then figuring out if they are meeting severe symptoms, the symptoms are very severe, affecting your life and academic performance and your social life, then I think they are ready for medication treatment. If the life is getting affected so much, right? You don't want them to be feeling miserable. Medications, when I start, I help them understand about that it's not, the depression is not something they make up, it's a medical condition that needs to be treated. And not always they can, talk it out of it, or
That's the truth.
yeah.
In therapy, here's something that I always notice when I see medication start to hit. Here's what happens in therapy. So, like, I'll be working with a depressed client who's unmedicated, who then
Hmm.
goes and gets treatment for medication. And initially, like, sometimes the first trial or the first dosage is the one, and it works. But oftentimes there's like two or three consultations with the prescriber, and then we nail it, like we hit the sweet spot for the medication, like dosage is appropriate or the right. And then what I see in therapy is this kid's flexibility of thought increases dramatically. So, like, this would be a kid who prior to knows what's going on, has insight about it, but cannot change the way they think, can't, and then suddenly they are on an appropriate medication, and they're like, whoa, I was just considering, it turns out I do have friends who care about me if I really stop and think about it. And I'm like, well, we've been talking about this for 6 weeks, but now you can hold that thought, right? Like,
Right.
it's a major change in flexibility of thinking, and then boom, we're off to the races with coping skills. And like, that's what I see. Like, suddenly what we've been talking about is sinking in, as opposed to you showing up for 50 minutes once a week, feeling good for 50 minutes or feeling hopeful, and then crashing and burning right afterwards. It's not, it's this wonderful symbiosis when the medication hits.
True. So the combination obviously is much better. If therapy continues, it gives you the life skills, the coping skills that you continue on. And I always say that in therapy, excuse me, in therapy, the skill sets that you're using, for a medication. So another common question for medications is this going to be lifelong? So
Yeah.
no. usually we give a trial. If it's the first episode of depression, we give a trial 9 months to a year. If you did great, then we can try taper you off this, so it's not for life. And then when there are, stressful moments in life, you can restart the medication if need be. So sometimes it's that. And then um, the other thing is that um, the medication wise, I always make sure that the parents are more responsible, because for teenagers, not the most important thing. The other things are more important
Yeah.
to them, the medication. So they have to be responsible, put alarms on, help them recognize that, if the medication, like you said, medication doesn't work right away, doesn't mean that, oh, I'm untreatable or nothing
Yeah.
works. We can always adjust the medication, because we always start small. I always tell them that, hey, we start small because we want to see if your body reacts good to it or not. And then we can always adjust, change the medicine. I'm here with them during this journey, right? And if anything, side effects or any problems happen, we can address it. So that's very important. Another thing is the question about black box warnings and parents getting worried about starting kids on antidepressants, given the fact that there is a black box warning which says that it can lead to suicidal thoughts. So, in psychiatry, almost all medications, even for adults, kids, all medications come with that kind of indication. But a lot of research has happened, and mostly it's the kids who are struggling with depression, who went unnoticed. They were not being monitors, or the parents or people around them did not recognize those signs, are the ones who end up in significant behaviors like self-harm or suicide attempts and all that. But kids who are monitored, who are getting the help, receiving therapy and medications, usually do better.
Mhm.
But there is a black box warning. It's a chemical. Sometimes it can interact. There are many theories about it. I'm not going to go into that. So yes, monitor for safety, even before medicines, even after medications. That's a must, because
Yep.
it's a life-saving thing. So you always monitor for that, but don't stop or don't delay seeking help or not take medications because of those. Talk to a specialist, so they can help you with your exact questions or hesitancies. We're discussing the main common misconception or main common hesitancy that the parent or patient would have in starting medication, that I'll be dependent on it. No, these are not illicit drugs which will be habit forming or addictive. But yes, they have a half life, they can have withdrawal symptoms, but it's not like an addicting medicine that you cannot live without. Um, so there are those things that are there. Um, but those are the most important thing. Do you guys think of anything else that we should address here in
No,
terms
I
of?
was just gonna piggyback on like the black box warning stuff. Like I always have a conversation, sometimes separate from the kid, with just the parents, that like, hey, when you go to pick up this medication, this is gonna be there. But knowing, I always tell patients, like, if there's a problem, if you're concerned that it might be going in the wrong direction, like, contact me immediately, stop the medication. Like, we're a team. And I think that, like, when you get that extra support wrapped around you, and like you find you have the supports, your kid has support, and like that is part of getting somebody better, to have that connection, with a trained mental health professional.
Mhm.
Absolutely. Yeah, that's why I tell them I'm here with you with you during this journey. There'll be ups and downs. I'm reachable, so please make sure that reach out. Because I mean, these are chemicals. Yes, if there's a side effect, you don't like something,
Yeah.
they cannot explain to me, like I'm trying to figure out their explanation of this is, side effect and akathisia or something. But sometimes when I'm like, you're the parent, you know your kid, something is, I go with what you're saying. You can stop it and we can meet again and discuss it,
Mhm.
so having that communication with your patients and parents is very important.
Mhm. This is this is a really tricky, as I said, it's a tricky subject. It's really a hard one for parents who are in the middle of it. It's awful to watch your vibrant child lose their spark, and that is what depression does.
Right.
And what I hope that people have heard today is that it's not, it doesn't have to be permanent. This is a highly treatable condition.
Yeah.
Of the psychiatric conditions, depression is highly treatable. And you don't have to deal with, you don't have to put up with, like a depressed adolescent or a depressed young person. They don't have to put up with that either.
And you don't have to put up with it alone.
Yes.
Seek help.
Yes. Seek help. There are people out there.
And exactly, and sometimes, like some of my friends said, this sometimes it is, there are delays. Then go reach out to your pediatrician if it's a milder form of depression. They will help and they will expedite the process. Reach out to your therapist, your family members too. Sometimes the kids feel that, oh, I'm going to burden my parent with this, so I don't want to talk to them. So I always also say that, hey, who are you close to? Who do you consider your support system? Reach out to them. And then, of course, things like, suicide hotline number on your speed dial, if that's the concern, safety in your house, make sure the medication cabinets are locked, make sure, firearms and weapons are all put away, especially during the time when they're seriously depressed, having suicidal thoughts, or they have started treatment, and started on the medication. So monitoring for that would be very, very important. And then the most important part, focusing on, if we can focus on healthy lifestyles, exercise, sleeping on time, sleep hygiene, eating balanced healthy diet, having good communication building good communication with our kids, understanding who they hang out with, who are these friends. When they're talking, try to listen to see what kind of topics they talk about, where are they coming from. So those are very important for recognizing and hopefully getting help earlier than later, right? If their behaviors are changing, things of that nature are very important, to develop good communication with our kids, not being judgy, but open listening. And listening means active listening. You're not like listening to what they're saying, but what's the content. If you're listening and they always talk about, I'm not good, I'm not smart, I'm this, then you're noticing that they're coming from a place of low self-esteem. So you'll be more careful and get them into therapy right away to work on that, and then how you understand and how you deal with your own child. Those are important things too.
Thank you for those important reminders. And thank you, listeners, for tuning in to this episode of Parenting Shrink Wrapped. It's, some of our episodes are sillier or more irreverent, and this one absolutely has not been on purpose, because the topic doesn't lend itself to that. And if you or someone you love is dealing with depression or suicidal thoughts, please contact someone who can help. Call the crisis line 988. There are national resources, there are local resources who are there and ready to support you or your loved one in a time of crisis. That's us. That's it for now. We're going to wrap up. Thank you for raising the next generation of world changers. We love you. We love your kids.
Thank you.
Thanks for joining us on this wild ride called parenthood here at Parenting Shrink Wrapped. We hope today's episode gave you some useful tools and maybe even a few laughs to help you navigate the twists and turns of raising teens and kids.
Remember, parenting is a journey, not a destination. And no matter where you are on the road, we're here to help you stay on course. Whether it's monumental meltdowns, teenage turmoil, or just the everyday chaos, you don't have to travel this path alone.
So until next time, keep your seatbelt fastened, your sense of humor intact, and your eyes on the road. We'll be back soon with more compassionate conversations and practical strategies to support you and your family.
Don't forget to subscribe to Parenting Shrink Wrapped wherever you get your podcasts so you never miss an episode. And if you've enjoyed today's show, we'd love it if you'd leave us a review and share it with a friend.
If you have suggestions for topics you'd like to see us cover in the future, feel free to send us an email at parentingshrinkwrapped@gmail.com.
Until we meet again, take care and enjoy the ride.